Hit the subscribe button or visit us at auau.auanet.org.
All right. Thank you very much. That was outstanding. And in the time that we have remaining, rather than go to a whole new breakout session, we thought we would just, we can use the chat function. You can type in questions. Our panel is still engaged. And if you have a burning question that didn't get answered, we're happy to help. I'll try to triage it to someone much smarter than myself, and that will help facilitate the answer. But let's go ahead and do that. Or even if the faculty have any discussion points they'd like to bring up.
Yeah, there was a question in our breakout about the Dr. Gamella. So this patient had both MSH as well as the DNA repair defect, the BRCA1, I think it was. Why did you choose olaparib first in that patient? Sort of what was it's a pretty unusual situation for sure, but just your thinking.
Well, you sort of have to realize the sort of the timing, when this patient actually came through the system, and there was great interest in high level of interest in the use of the PARP inhibitors. So that was what the team decided to do. But I do think that we tend to use the oral PARP inhibitors. I defer to Dr. Morgans and Dr. Lang a little bit before we go to the things like the Pembro for systemic therapy. So I think we like to use the oral agents and the PARP inhibitors, and we tend to keep the Pembros and those in abeyance. So I don't know if my knowledgeable medical oncology colleagues, Dr. Lang or Dr. Morgans, feels differently about it.
I actually think I would favor Pembro over olaparib just in terms of the tolerability profile. And maybe that's because I have an infusion facility, so it's different when you're decision making, like I have access to that. It's really easy for me to do that. And if I see that a patient has a high likelihood of responding to Pembro with a low likelihood of complications, then that's a direction I might go. Now, a patient with a BRCA2 alteration, that's a really compelling mutation. Even PALB2 has been, at least in my experience and in some of the exploratory analyses of mutation based responses, seems to be a pretty responsive alteration. And so that might be a different calculus. But at the end of the day, we actually don't know for any one patient whether the patient's going to respond, whether it's these targeted therapies or are tried and true, things like chemotherapy. So there isn't a right answer, and it is really just what you have access to, what the patient feels comfortable with, and many patients prefer oral. So I think that it can come down to these patient preference conversations and what physicians are able to do easily. And Josh, I wonder what you think.
Question though, just one comment. I mean, it's not wrong to do what we did, right? Can I
no, it is not
defend our honor here that it was wrong?
No, you did great. The patient had a super response, right, Lenny? The patient had a super response. That means it's right.
Yeah.
Thank you.
I think what I would add is that we're looking for shots on goal. Our intent for this patient population is to get them as many different therapies as possible to improve survival. So I think this is where there's logistic issues, again, as Dr. Morgan said, of, what's the insurance coverage for these different agents? What accessibility do I have for these different therapies? So in my clinical practice, I generally say, I'm going to send off insurance authorizations for both drugs, and whichever one I can get faster. I think especially for someone who has symptoms from their disease, I'm more likely to get, a response, especially if I see both somatic and germline BRCA2 mutations. So someone with symptomatic disease and that mutation profile, I'll probably get faster response from a PARP inhibitor. However, in somebody who, if I've done my sequencing early and allows me to map out that sequence of agents, ideally months, if not years ahead, then I can say, you're actually feeling really good. And pembrolizumab has, generally speaking, a lower toxicity profile. Let's give this a shot. And if it works, awesome. We're going to ride that horse as long as we can, but then be able to pull that trigger really quickly to switch to the PARP inhibitor if it doesn't. again, it really depends, I think, on that clinical context of where the patient is at. So short answer is I agree with both of you.
Thank you.
Josh?
For being thank you for being Switzerland. But to your point, something came into my inbox. I don't know, from Cancer Therapy Advisor or MedPage, basically saying how much the financial toxicity is for patients with oral cancer drugs versus the infusion drugs. And I don't know if you guys saw that, but I think that was some, I don't know, it came out, but in the last 48 hours, mentioning you're better off with an infusion. It's going to be less out-of-pocket costs for the patient than the oral agents.
So
That is definitely
actually,
consideration too.
Lenny, that was our study that was just highlighted. So that's a study that was done by one of our fellows that's in JRL looking at out-of-pocket costs.
Great.
But could I ask a question just related to that came up in our chat room from Lenny's case that maybe Alicia or Josh has? Guideline indications to obtain germline testing fairly clear, new diagnosis high-risk patient or new diagnosis metastatic patient. But the question that was asked was when to get that somatic testing. When do you stick the met? If it's high volume, newly diagnosed hormone sensitive disease, it's not going to be the next treatment. And maybe treatment is going to change the profile of that met down the road. So the question I was asked, which I again defer to those here, when should that biopsy, the somatic tissue, be obtained in the disease course?
I could jump in and then Alicia, please. I generally speaking, anytime a patient presents with metastatic disease, that's the time to do your first round of somatic tumor testing. The reason I do that is, again, we're still going to give that doublet or triplet therapy, but it allows us to start asking, okay, is this somebody that we should be thinking early on about germline testing, thinking about PARP inhibitors or other, again, what do we do down the road? But also if I happen to see a pre-existing P53, P10 or other high-risk RB mutations, those are patients, if I was thinking about doing ADT plus an AR therapy, but I see those high-risk mutation profiles, again, they're prognostic, I would really think strongly about triplet therapy in that situation instead. Now, the next time I do testing is when patients have new CRPC. This is, again, because it's so urgent to be thinking about, if they've had prior a second generation AR inhibitor or not, we need to start setting up the stage for, are we going to think about a PARP inhibitor down the road? Are we going to think about pembrolizumab? The frequency is low, but the other thing that I'm looking for, again, with new CRPC, especially if they progress on abiraterone, is this someone who's developing a neuroendocrine signature? So that's also going to prepare my patients to say, do I feel more strongly about chemotherapy in this situation or radium-223, depending again on where you're at in your clinical situation? Does it drive me towards a clinical trial? If I have a PI3 kinase mutation and I've got a trial with that as an option, I'm going to think more strongly about that as well. So those are really the two times I really strongly think about somatic tumor testing. And then after that, it's really driven if I see a change in the disease. If I have somebody who's had lymph node only disease, but now they have either bone or visceral disease, again, that's going to change my recommendations, especially if it's even going to push me towards a platinum doublet. That prognostic information, I think, is really critical at those particular time points. With also the caveat of before you do blood testing, be careful with that, because if a patient is responding to therapy, your risk of getting a false positive or a false negative with circulating tumor DNA testing is extremely high if someone is benefiting. Only do that when patients have radiographic progression.